Hi there, my highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, I humbly urge you to sit back and spare me part of your very precious time to share some tips which may empower you to effectively deliver pharmacotherapy services in your line of duty. So welcome to part 46 of our MCQ series that majors in neurology. So our first question reads, which of the medications listed below can increase the risks for seizures in epileptic patients or those with medications which lower seizure thresholds? Is it Oxazepam, which is marketed as Serax, or is it Zonisamide, which is marketed as Zonegran, or is it clozapine, which is marketed as Fazaklo or Chlorazil, or is it Zafirlukast, which is marketed as Aqualit? I'll give you 10 seconds to choose the correct answer. So, clozapine it is. Now, clozapine is well known as an atypical second-generation antipsychotic agent which lowers seizure threshold. Now, zafirlukast is a leukotriene receptor antagonist that is most commonly used in the treatment or the management of asthma and allergic rhinitis. It doesn't increase risks for seizures at all. And zonisamide is an anticonvulsant and it would prevent seizures. So that makes it the wrong answer. And then oxazepam, Serax, is a short-acting benzodiazepine that could actually decrease risks for seizures. So that too would be the wrong answer. Let's move to the next question, please. Mr. XPD, a 58-year-old male suffering from epilepsy, presents to your hospital with a creatinine clearance of 26 mL per minute, and your team plans to prescribe an anticonvulsant for XPD. So my question to you is, which of the agents listed below wouldn't be recommended for Mr. XPD, bearing in mind that he has severe renal impairment? Would it be Pregabalin, marketed as Lyrica? Would it be Perampanel, marketed as Fycompa? Or would it be gabapentin, marketed as Neurontin? Or would it be lacosamide, marketed as Vimpta? I'll give you 10 seconds to choose the correct answer. So B would be the correct answer, Perampanel or Fycompa. Now, Perampanel is an anti-epileptic drug which is administered once daily at bedtime. It isn't recommended in patients with severe renal impairment or those undergoing dialysis because it hasn't been studied in this population. Both Pregabalin and gabapentin are drugs that can be used to relieve neuropathic pain, and they're also used as adjunct anti-epileptic agents. They are administered orally in 2 to 3 divided daily doses. They have information in literature concerning renal dosing. You can do dose adjustments in patients with severe renal impairment. Now, lacosamide or Vimta is an anti-epileptic drug which is administered orally twice daily. It can also be administered via short-term IV injection, when patients cannot take medication orally. It too has information on renal dosing in literature, so you can adjust doses in patients with severe renal impairment in the case of lacosamide. So the correct answer there, because of the many words I've mentioned, is Perampanel, which is Fycompa. Let's move to the next question, please. The next question reads, Mrs. G.O.N., a 33-year-old female nurse, visits your pharmacy to fill a new warfarin prescription. She was diagnosed with ischemic stroke 2 days ago at your hospital, and she plans to purchase over-the-counter oral mono contraceptives as well. So my question to you is, which of the recommendations listed below would you propose to Madam G.O.N. in order to reduce her risks of a future stroke? Would you propose she procures a low estrogen combined oral contraceptive? Or would you suggest she purchases a levonorgestrel intrauterine device? Or would you suggest she uses a barrier method for contraception? Or would you suggest she procures ethinyl estradiol and etonogestrel vaginal rings for her contraception? I'll give you 10 seconds to choose the correct answer. So I would advise her to purchase the intrauterine device. B would be the correct answer there. The failure rate with the typical use of barrier methods for contraception in literature is quoted as 12 to 23%, depending on the method used. Some of the methods may include a cervical cup, the male condom, the female condom, a sponge, or a diaphragm. None of them gives you 100% surety. They can fail you in up to 23% of cases. So that makes answer C wrong. Oral estrogen containing contraceptives aren't recommended in patients such as this one with a history of VTE, MI, or stroke. Although the risk of primary stroke with these agents is unclear, in my opinion, a history of previous stroke provides an additional stroke risk factor. So I would not dare use them in her case. Now, since there are safer options, I would shy off from estrogen containing contraceptives as much as possible. So even D becomes the wrong option in my opinion. Now, the vaginal ring contains ethinyl estradiol, and that should be avoided for the same reason as I've explained earlier. Then levonorgestrel intrauterine devices, progestin only pills, and etonogestrel implants are options for women with a history of ischemic stroke. So those are the ones I would settle for if such a patient sought my advice concerning the need to avoid conceiving. Now, I would just like to emphasize that estrogen-containing contraception poses a high risk of clot formation, so shy away from them in such scenarios. Let's move to the next slide, please. So the question reads, your neurology team orders a TPA for Mr. J.W., a 67-year-old male patient who has an acute ischemic stroke. And as the clinical pharmacist in that unit, you perform a thorough medication review, you do medication reconciliation for J.J.O.'s case, and you establish he took his last dabigatran dose in the morning. A few hours have elapsed. So my question to you is, which of the interventions listed below would be the most appropriate for Mr. J.J.O. now? Would you recommend the administration of either rusizumab, then the discontinuation of the TPA, or would you totally choose to discontinue the TPA, or would you recommend administration of either rusizumab and then proceed with the TPA, or would you recommend an APCC and then proceed with the TPA? I'll give you 10 seconds to choose the correct answer. So B is the correct answer. I would choose to discontinue the tissue plasminogen activator. Now, patients receiving the dabigatran who have had a dose within less than 48 hours and who have normal renal function should not receive TPA for acute ischemic stroke. While there are case reports describing reversal with either rusizumab, this practice is not supported in clinical practice guidelines. Now, the novel anticoagulants, the novel oral anticoagulants, reversal prior to or to facilitate TPA for stroke, in my opinion, is not recommended. Now, concurrent NOAC therapy may actually sensitize clots to TPA, and it does that by preserving what we call the lysine binding site of the plasminogen itself. However, the risk of bleeding outweighs benefits at this particular time, so I would not go there. Now, certain coagulation studies can identify NOAC activity. However, the availability and the time required to return results renders them useless, in my opinion, considering the 45 to 60 minutes time window for TPA in acute ischemic stroke. By the time you get the results, the stroke would have caused havoc. Time is brain in this particular case. Now, TPA can be administered prior to a patient undergoing interventional radiology clot retrieval procedures. It's allowed. So that's just a by the way. Let's move to the next question, please. It reads, which of the anticonvulsants listed below worsens absence seizures, the petit mal? Is it valproic acid derivatives such as depakine? Is it phenytoin, marketed as dilantin? Is it ethosuximide, marketed as Zarontin? Or is it levetiracetam, marketed as Keppra? I'll give you 10 seconds to choose the correct answer. Correct answer is dilantin, phenytoin. Valproic acid, ethosuximide, and levetiracetam are all used to treat obscene seizures, which we also refer to as petit mal. Now, patients with obscene seizures shouldn't take phenytoin, they shouldn't take carbamazepine, and they shouldn't take phenobarbital, because all these three drugs increase the frequencies of such seizures. Now, other treatment options, as I said, include levetiracetam, lamotrigine, zonisamide, or clonazepam in such cases, such as in the cases of petit mal seizures. Now, these drugs should only be considered if other options can't be used. So let's move to the next slide, please. And the question reads, Mr. J.W.W, a 77-year-old male patient, presents to your neurology clinic with a primary intracranial hemorrhage, which is abbreviated as ICH. He currently takes 25 milligrams of carvedilol orally twice daily, 10 milligrams of lisinopril once a day, and 2.5 milligrams of warfarin orally once a day. Some of his vitals include a heart rate of 90, a systolic blood pressure of 138, and a diastolic blood pressure of 75. His body temperature is 98 degrees Fahrenheit. He has a respiratory rate of 16 breaths per minute, and is saturating well at 99% on room air. Now, your team makes a decision and administers fresh frozen plasma in order to lower Mr. J.W.W's INR. They feel it's too high. 30 minutes after transfusion is completed, Mr. J.W.W. complains of shortness of breath, and his vitals are as follows. His heart rate shoots to 130, his systolic blood pressure shoots from 138 to 178, his diastolic blood pressure shoots from 75 to 95, his temperature remains the same, and his heart rate shoots all the way from 16 to 45, and he begins to desaturate. It's now at 83 from 99%. So my question to you is, which probable adverse reaction occurred in J.W.W's case? Is this a case of tension, pneumothorax? Is it a transfusion-associated cardiopulmonary overload? Is it a case of aspiration pneumonia? Or is this a type 4 allergic reaction? I'll give you 10 seconds to choose the correct answer. So this is a case of transfusion-associated cardiopulmonary overload. Now, we know that patients receiving large volumes of fresh frozen plasma, particularly those taking oral anticoagulants and those with underlying cardiovascular disease, are at a risk of transfusion-associated cardiopulmonary overload, what we abbreviate as TACO, TACO. Now, fresh frozen plasma largely remains in the intravascular compartment, where patients with impaired cardiac function may not be able to compensate for the volume overload. Now, in such patients, consideration for prothrombin complex concentrates, which contain coagulation factors but less volume, should be considered instead of fresh frozen plasma. I would also like to add that while transfusions may cause allergic reactions, in my opinion, a type 4 hypersensitivity reaction is a cell-mediated reaction that takes many hours to days to develop. It can't happen within half an hour. So that makes D the wrong answer. I'd just like to add that TACO, transfusion-associated cardiopulmonary overload, is an recognized adverse event from blood product transfusions. In patients receiving blood products for reversal of anticoagulants who likely have impaired cardiovascular function such as heart failure, atrial fibrillation, or pulmonary emboli, such patients are at particularly high risk, in my opinion. Now, clinicians must consider the total volume required to reverse a given anticoagulant and the potential prothrombin complex concentrate agents available as an alternative with low volume strategies. Now, blood product transfusion requires their own IV line. Don't use the same line to administer those antibiotics, antipyretics, and the rest. No medication, I repeat, no medication should be infused using the same line as that you use to administer blood products. Now, it's also advisable that vitamin K, Conaquion to be specific, should be administered concomitantly with other reversal agents for patients taking warfarin. And those are just by the way, as points of information. Let's move to the next question, please. And it reads, Mrs. R.K.M, a 56-year-old female with non-small cell lung cancer complicated by a pneumothorax, was admitted at your hospital 3 days ago. She was intubated on arrival, and some of her medications include MS-Contin at a dose of 30 milligrams orally twice a day. That is prior to admission, alongside immediate release morphine at a dose of 15 milligrams every 4 hours in case of breakthrough pain, alongside 20 milligrams of paroxetine after breakfast, and Senna at a dose of 8.6 milligrams once daily because the opioids constipated her, and she was also on 50 milligrams of trazodone. Now, on admission, some of our meds include Propofol infused at a rate of 60 micrograms per kilo per minute, and morphine administered at a dose of 1.5 milligrams per hour IV, alongside 8.6 milligrams of Senna to relieve constipation, and with an allowance to go all the way to 50 milligrams per day via NG tube. And then for the stress prophylaxis, the team chose to administer 20 milligrams of esomeprazole IV once daily, and because most of the time she remains lying, they chose to do thromboprophylaxis with 40 milligrams of enoxaparin administered once daily subcutaneously. Now, this morning, Madam R.K.M.'s sedation agitation score, what we abbreviate as SAS, is 5. Her behavioral pain score, which we abbreviate as BPS, is 3. And her confusion assessment method, what we call CAM-ICU, is negative. The nurse states that the patient has been increasingly agitated. So my question to you is, which of the options listed below would be the most ideal choice for managing Mrs. R.K.M.'s symptoms? Would you choose to increase the Propofol dose, or would you choose to administer morphine at a dose of 15 milligrams via NG tube every 6 hours, or would you opt to resume paroxetine and trazodone that were excluded from her list of inpatient medications, or would you initiate dexmedetomidine? I'll give you 10 seconds to choose the correct answer. So C is the correct answer. I would resume paroxetine and trazodone, which were excluded from her list of inpatient medications. Now, Madam R.K.M. has a BPS that indicates well-controlled pain. Now, the SAS score of 5 indicates agitation, in my opinion, and the confusion assessment method CAM-ICU is negative for delirium. Now, we know that abrupt cessation of selective serotonin reuptake inhibitors like paroxetine and other neuropsychiatric agents may be associated with symptoms of withdrawal, such as agitation, for example. Now, the SSRI withdrawal is more likely to be observed in patients taking agents with short half-lives. These agents should be continued when patients have attained hemodynamic stability and where entero access is available, when they can comfortably take medication orally, either by swallowing or by a NG tube. Now, initiation of dexmedetomidine, in my opinion, might help with the withdrawal from neuropsychiatric substances, but Mrs. R.K.M.'s antidepressant therapies are chronic and will need to be resumed eventually. Then A, high infusion rates of Propofol have been associated with what we call PRIPS and hypertriglyceridemia. Now, we know that R.K.M. has a potential explanation for the increased agitation that should be addressed prior to titrating Propofol. Remember, we excluded paroxetine and trazodone, and that's the main cause for increased agitation. So I would not be too quick to titrate the Propofol dose upwards. So that makes A incorrect. Now, I would also like to add that R.K.M.'s morphine adequately replaces her chronic oral morphine requirements based on her BPS scale. Now, prior to initiating a sedative or making a dose increase in response to new or worsening agitation, such patients should be assessed for potential sources or as potential source of agitation, and we should make efforts to correct those sources if possible. Just like to add that potential causes of agitation in such patients may include uncontrolled pain, for example, delirium, withdrawal from chronic psychoactive agents, alcohol or illicit drugs, even noise and physical restraint can cause the same. Then I would like to add that SSRI discontinuation syndrome may present at for example, gastrointestinal, sleep, balance, and even sensory disturbances, as well as agitation and irritability. That's why I feel that having left paroxetine from his regimen may be a major cause of his agitation. I would also like to add that chronic psychoactive medications should be reinitiated in hospitalized patients as soon as the patient's clinical status allows it. Now, SSRIs have antiplatelet activity that has been associated with increased risks or rate of bleeding, especially in patients undergoing invasive surgical procedures. Now, a dose-dependent QT prolongation effect has also been identified with one of the SSRIs, which is citalopram to be specific. And because of this, doses of above 40 milligrams per day in normal patients or above 20 milligrams per day in the geriatric population is not recommended. Yeah, there would be arrhythmias, so we have to be very careful when using these agents in the old. And then I would just like to also emphasize that when resuming serotoninergic home medications, the total serotoninergic burden should be considered. Yeah, since in the course of admission, drugs with serotoninergic activity may have been initiated, assuming this patient had been put on linezolid or tedizolid, which are monoamine oxidase inhibitors. There would be a problem. So you have to look at the bigger picture, yeah, for the patient to be on the safe side. You have to consider the entire serotoninergic burden. Let's move to the next question, please. The next question reads, your neurology team chooses to treat restless leg syndrome, abbreviated as RLS, in a 51-year-old woman admitted to your hospital using ropinirole. She has moderate symptoms occurring mostly at night. She has unsuccessfully tried non-pharmacologic treatment. So my question to you is, how would you counsel this lady to take her ropinirole? Would you advise her to take ropinirole every morning to prevent daytime symptoms? Or would you advise her to take ropinirole in the evening 1 hour before bedtime? Or would you advise her to take ropinirole twice daily to prevent daytime and nighttime symptoms? Or would you advise her to take ropinirole in the evening at bedtime? I'll give you 10 seconds to choose the correct answer. So I would advise her to take it in the evening 1 hour before bedtime, and I'll tell you why. Ropinirole should be taken between 1 and 3 hours before bedtime. It is rapidly absorbed and it reaches peak concentrations in 1 to 2 hours after administration, so that the concentrations are available in the CNS when the symptoms are greatest. Remember, RLS symptoms are typically mostly bothersome at rest or in the evening. Now, since this lady has bedtime symptoms, the daytime ropinirole dosing, in my opinion, would not be beneficial. So that makes alternative A wrong, in my opinion. And I would just like to add that ropinirole was dosed 1 to 3 hours before bedtime in clinical trials when they are establishing the correct dosing, and this is presumably to ensure adequate serum levels by the time the patient goes to sleep. Now, ropinirole is dosed once daily for restless leg syndrome, RLS, but it may be dosed more frequently for Parkinson's disease. Actually, they use a TDS regimen, unless, of course, their formulation is extended release. So that's just a by the way. Let's move to the next question. It reads, Mr. G GBY. A 68-year-old male presents to your neurology clinic with a primary intracranial hemorrhage, what we abbreviate as ICH. Some of his lab values are a serum creatinine of 2.6 and an INR of 3.3, bit high. His actual body weight is 85 kilos, and some of his vitals include a heart rate of 70, systolic blood pressure of 208, diastolic of 108, it's pretty high. He has a body temperature of 98 degrees Fahrenheit and a respiratory rate of 16. He is mechanically ventilated and the FiO2 is 60%. Your team would like to lower this systolic blood pressure to between 140 and 160 millimeters of mercury. So my question to you is, which of the antihypertensives listed below would be the most appropriate for Mr. GBY? Would it be sodium nitroprusside? Would it be diltiazem? Would it be clevidipine? Or would it be metoprolol succinate? I'll give you 10 seconds to choose the correct answer. So clevidipine it is. Now, I would just like to start by saying that clevidipine is a dihydropyridine calcium channel blocker, and it's the ideal drug for GBY's case due to its rapid onset, which is 2 to 4 minutes if I remember well, and a short half-life, a terminal half-life of around 15 minutes to be specific, and both of those two allow for rapid titration of the same. It doesn't cause bradycardia at normal therapeutic doses, and it may cause favorable cerebral vascular dilatation. Now, alternative B, which is diltiazem, isn't an appropriate agent given its primary negative chronotropic effects, so I would not settle for B. Then alternative D, metoprolol, isn't ideal given that GBY's heart rate is 70. Now we know that the doses required to control blood pressure would increase the risks of bradycardia in the case of Mr. GBY, and would also cause a decrease in cardiac and cerebral perfusion. So there would be a danger there. Now we also know that metoprolol succinate, the extended release form, only appears in tablet form. It does not have an IV formulation. It's the metoprolol tartrate that has both oral and IV formulations, but all the same, it's not a suitable option. Then A, sodium nitroprusside, in my opinion, isn't the best choice for Mr. GBY either, because we know that his current serum creatinine, if I remember well, was 2.6 milligrams per deciliter. And yeah, in my opinion, there is a risk of accumulation of thiocyanate and a great risk of CNS side effects. So I would not opt for A. I would just like to emphasize that hypertension must be controlled in patients with intracranial hemorrhage, and because this is, in my opinion, considered a hypertensive emergency given the end organ damage that may result. Now, caution must be taken not to lower the MAP precipitously, and yeah, that's just to avoid hypoperfusion of brain tissue, which could cause further secondary injury. Now we know that clevidipine is supplied as a 20% lipid emulsion, and It should not, I'll repeat, it should not be confused with Propofol, which also comes as a 10% emulsion and is visually very similar to clevidipine. Now, hospital pharmacies should endeavor to classify them as LASA, look alike, sound alike, because of the fact that they look alike. And we know that such patients like this gentleman will most likely be mechanically ventilated and sedated, and there's a very high risk of medication errors if they are receiving both clevidipine and Propofol. So be on the lookout. Ladies and gentlemen, my highly esteemed viewers and listeners, that brings us to the end of part 46 of our pharmacotherapy MCQ series. Now, if this video benefited you in any way, I would like to urge you to remember to give it a thumbs up and to like it and to share it widely with your peers. And if you haven't yet done so, I would like to humbly urge you to subscribe to my YouTube channel. And I would like to promise you and other viewers that the best is yet to come. I would like to sincerely thank you for viewing and for listening to this video. I sincerely appreciate your partnership and your continued support and collaboration. And I look forward to interacting with you in part 47 of our pharmacotherapy MCQ series. Thank you for always being there for me.